Hello, everyone. Welcome to the Flint Community Webinar, your community resource every Friday at noon. I can't believe we are already in the middle of August, right? I've already looked outside and we've got some leaves changing, and I know people are getting ready for school. So we will have programming and great resources to talk about that. This week, we're really excited to talk to you about a really important topic in our community. We're going to be talking about men's health, and we have the luxury of being able to get into a lot of different aspects of that. We're going to be talking about men's preventative health, and Dr. Aisha Harris is going to help us understand a little bit about that. We're going to be talking about mental health and nutrition, and shout out to Dr. Shan Jackson, who's going to be talking to us about that. And we've always got Dr. G and Nurse T with their feedback from the field. We want to start this session by giving you some context for things we need to pay attention to with regards to men's health in Flint. So we're going to bring back the HERC and talk a little bit about the things we're seeing in Flint and the areas on the HERC that are really relevant to men's health and the things we need to be thinking about. Thanks so much, Heatherlyn and Blair, for all the work you've done with the Flint report card.
We're excited to talk about this important resource for the community, and we'll be putting some links in the chat. Hopefully everyone has it, because we've been talking pretty consistently about the health equity report card. But just to remind folks what it is, it's an opportunity for us to take available data and do what's called disaggregate it, or break it down by location, so that we can see disparities or differences between location, so Flint and Genesee County, and Michigan, and then Genesee County and the US, as well as by race, which for us is individuals who identify as Black, and then those who identify as white. So those are the two big categories that we have the data broken into. And what we've done is, because of today's topic, we're going to walk through some particular data points that, will set the stage as we enter into conversation with our other guests today. So EJ, Blair, you and I were talking earlier about, on this page here where we see health services and access, this is disaggregated by race. You can see that in the upper right-hand corner of your screen. And we've identified cost prevented care, HIV testing, and preventable hospital stays as areas that we wanted to hone in on. They all have received a C. And before I get too far into that, I want to just draw everyone's attention to the top, where we have outlined the key, or the kind of grade for these disparities. And what it shows us, again, it doesn't tell us the full story. It just tells us the differences and how we should contextualize those differences. What we're seeing here doesn't necessarily tell us how are we doing as a community in that area overall, but just says what's the difference.
So that reminds us of that conversation we were having about areas where we just might not have great data at all, right? Places where we might need to do more work and looking at our data sources and getting more information. And I appreciate the context that you gave us, that in while we should be, thankful for the resources that have gotten us there, right? And really sort of highlighting the resources that we've that have gotten us there, doesn't mean that we're done or that there's no more work to be done in that particular area. It probably means that we need to focus a little bit on the areas that have C grades and think about new resources, or how we make sure people are accessing those resources.
Exactly. And celebrate the successes, right? So, your eye is drawn to the A's for health insurance coverage, right? And that is a testament to the wonderful work of the Genesee Health Plan, other organizations who are addressing that need in our community. But you can see in the bottom right-hand corner that there's still work to be done, right? So these are individuals ages 0 through 65 who lack insurance coverage. And what we're seeing is that almost 95% of the population has insurance coverage. And then the breakdown is roughly 94% for Black population, roughly 95% for white. So we're doing great work in the community for this, but there's still room to, number one, support the existing work and then expand it so that we can ensure that everyone has access.
So I have a few questions because I'm seeing like we're doing good work in health insurance coverage, but those and we've got an A, but then we look at our uninsured data, right? And you would think maybe that those would parallel each other, right? If we're doing great with health insurance coverage that maybe our uninsured would match. And maybe you can help us tackle that a little bit.
Yeah. So, and Blair joined me in this because you really have led so much of this great work. And I'm just so grateful to get to work with you. But again, what this is showing us is differences. So the A is saying black and white, pretty close, right? And then uninsured, when we see this category, notice that asterisk. And this was a complicated thing to kind of figure out. How do you communicate who's doing worse, who's doing better, that still maintains the simplicity and, you know, why we're doing the health equity report card. But in this case, the asterisk means that the white population faces worse outcomes around being uninsured.
And
Go ahead.
just to add to that, so we also, within the health equity report card, there's also definitions for each of these indicators, especially the ones that maybe, you know, definitely would need a definition. For example, cost preventive care. You know, what does that really mean? For example, that means could not see a doctor because of cost in the past year, but also the difference between health insurance coverage and uninsured. Health insurance coverage is defined as the people who have health insurance coverage. And then uninsured is people who currently lack health insurance coverage, age 0 to 65. So there is a slight difference between those two indicators. One is, you know, the whole population, and one is a specific age range. It is a big age range, but, you know, that's an important difference.
That's really helpful. And I'm guessing uninsured probably and health insurance coverage, both of those don't get at this other idea of partially insured or not, you know, completely insured and getting the resources that they need.
And what that coverage really entails.
Yeah. So we don't instinctually make a connection between why having adequate health insurance coverage is related to men's health. But as we were talking to some of our colleagues, I thought it was interesting. I think it was Dr. Shan who said, you know, men don't really instinctually like to go to the doctor, right? They might have to be, you know, prodded a little bit more than women to go to the doctor. And it strikes me that particularly if you have another barrier, that electing to go to your doctor is going to be even harder. Is that something that you all would agree with based on the data you've seen?
Definitely. You know, if you have any hesitancy, any mistrust with physicians, or, you know, concerns about, or if you just don't have access, if you can't make it to the doctor at a time when the clinic's open or your doctor has an available appointment, so many barriers, transportation, we could go through the list, right? If you already aren't amiable, if you already are kind of like, I don't really feel like going to the doctor, I'll just put up with, you know, whatever symptoms I'm experiencing, those additional barriers just make it even more difficult.
Distance, even, you know, the difference between like 15 minutes to a location, health service location versus, you know, 30 minutes
is going to make the difference between someone feeling like they can accomplish that. Okay, this is really helpful information. Let's get into the next slide that we're talking about.
So here we're looking at socioeconomic status, and we pulled out a couple here where we're seeing poverty and unemployment. And you can see that in particular in Genesee County, we're seeing some real challenges. This is by race again. So we are seeing that our African-American Black population is facing worse outcomes, particularly in Genesee County, but nonetheless in Flint as well. And then that spreads. So it's not only Genesee County, we're also seeing it in Michigan, and we're also seeing it in the US.
Can you explain what this means? So if I'm looking at poverty and I'm looking at the US has a D, Michigan has an F, Genesee County has a D, and Flint has a B. Blair, tell me what that means.
Yeah, so basically, you can refer back to that key up there. So the D is disparity requires intervention, and that represents a disparity ratio of 2 to 2.4. So basically, we're looking at the rates for poverty, for example, and the difference between Black and white populations in Genesee County, for example. So we get those hard numbers, and then we calculate the disparity ratio based on those numbers. That gives us the letter grade, and that shows us that there, is a wide disparity for poverty between Black and white populations in Genesee County. And we got these disparity ratios. We got them from looking at previous health equity report cards in different areas, different communities across the country. And we found that across the board, this is generally how people would break down disparity ratios. But we found one through Nebraska, their health equity report card, that was the most straightforward and clear, easy to understand. So we stuck with that one, and that kind of helped us come up with these
The infrastructure
grades
together.
Yeah.
So if I were looking at Flint for poverty, or even Genesee County, I could say that the outcomes in terms of comparison are better than what we see at the state. Maybe better than what for Flint, better than what we're seeing in the country.
Yeah, the disparity. Yeah.
This is a breakdown by race. So when we look at the Black-white comparison in Genesee County, our Black population is doing worse in Genesee County. They're doing worse in the state of Michigan, and they're doing worse in the US.
Exactly.
Yeah.
And go ahead, Blair.
Oh, it's important to, and Heather, you already kind of mentioned this, but a little to no disparity or difference. So, an A or B grade, for example, that does not mean that there's adequate health services, access, behaviors, outcomes. It simply means there isn't a large difference between race or geographic locations, depending on what we're looking at, for this health indicator. So, maybe there's not a large difference, but that doesn't mean that the outcome is good, in the community.
Fantastic. All right, let's look at our next slide.
So here, and we haven't really gotten a chance to talk about all of the maps that are included in the health equity report card, but here's one that really demonstrates socioeconomic distress, right? And this is broken down by census tract. A little bit of information for folks who joined us. The reason we are focusing on census tract is that if you're familiar with the Flint community, a whole lot can happen in a zip code, right? Depending on which section of the zip code you live in, you might have a very different experience of life. So it's real important that, because we want to be as accurate as we can with the data that we have available, we've selected census tract, which is what the census uses as well. Here, you can see a comparison where on socioeconomic distress, the darker the green color, the higher the distress. And then on the right, you can see our population, where the darker the colors, where we see more of our African-American Black population living. And you can see the patterns. The patterns are distinct.
So again, linking this back to our conversation about men's health, right? All of these sort of stack up as barriers to eventually getting care, right? And really sort of have implications long-term in terms of wanting to go see your physician.
Yep. And that socioeconomic distress definition, this is also included in the HARC. And here's the other thing, as folks are going through the report card, if you find something and you're like, this isn't clear, you could do it better this way, please tell us. This is a resource that we want to be usable for our community organizations, our grassroots organizations, and our residents in Flint. So please, we want your feedback. We would be very grateful for it. So we've included those definitions, and we didn't really talk about what this is. So the official definition of socioeconomic distress is a census block group level variable referring to the amount of material and social deprivation So single parenthood, poverty, low education, all of those things combined into one score. So it's not just how you doing money-wise, or do you have a house? It's taking all of those into consideration. So it really offers a really good indicator of socioeconomic status. The next one we have is mental health. And we did some different colors here because we wanted to talk about some successes, some areas that have less difference, less disparity, and then some areas that really are experiencing some high disparity.
And Blair, why don't you, so we've got two circles here, right? We've got depression and we've got sort of in purple, and then we've got suicides. And so depression, again, is that area where we've described as little disparity, but there's this distinct sort of lower grades that we're seeing with suicides and suicides by firearm. I wondered if you'd talk a little bit about that.
Yeah. So we are seeing more suicides and suicides by firearm in the white population. That's across the board in the US, in Michigan and Genesee County, and in Flint for suicides by firearm. So there is a higher rate of suicides in the white population, and that's also connected to someone mentioned men. There's a higher rate of men with suicides.
Absolutely. I think Dr. Shan was going to talk a little bit about that and what we're
so I'll
seeing
just
in our community.
pass the baton to her at the time.
Yeah.
But yeah, and then another thing here is that there is a lack of data for mental health. And also you can see, especially for Flint, and that's across the board for the report card. We tried to fill as many gaps as we could with data, but there's definitely room for more data collection or,
looking at different resources.
Yeah.
And really kind of fleshing out the data. This is a point we keep driving home, this idea that one, grades again don't mean that there's no work to be done, but there's also opportunities for us here where we work with our community partners who might have access to data sources that can help us flush some of this out. Dr. Shan was already talking about distinctly how men sort of experience depression and suicides, and we're not necessarily counting them, or we're not necessarily realizing the prevalence and how important it is to have discussions around this. So I think it's a really well taken point, and something that we need to be thoughtful about. Again, this gets at the idea of we're thinking about men's preventative health across the spectrum, and that includes thinking about what mental health looks like.
And real quick, you might be thinking, what is poor mental health? Like, how do you categorize that? Everybody has good days, bad days, and whatnot. But for this particular variable, it is that your mental health has not been good for greater than or equal to 14 days for individuals who are over the age of 18. But here's the other thing. We only have 4 variables here. We know, we've had so many of our partners from the Genesee Health System and other partners who've come in and talked about other variables that are important when we examine mental health. So this is only, a small portion of what we hope to include in the future through future iterations.
All right.
So here's another map. And again, this is the demonstration of poor mental health by census tract. The darker the blue color, the poorer the mental health. Again, that 14-day window. And you can see we've got some different communities that have popped up, but look at the patterns.
Yep.
We turn our, this is a whopper slide. We were putting this together and like, oh, here we go. So folks, I apologize if you can't see it.
No, but we can call this out. We can disentangle it a little bit.
It's a lot.
So we do, go ahead, EJ.
So I think I actually said it's important for us to think about this in context a little bit, right? So we're talking about men's mental health. I wanted to see sort of the big areas that we sort of talk about in the community, or that I know I talk about with patients and Dr. Harris is talking about with patients, and give some context to people for what that looks like in the community. And so looking at colorectal screening, knowing the change guidelines, and Dr. Harris will talk a little bit about that. Looking at what our disparities look like for colorectal screening, look at what our disparities look like for diabetes screening, high blood pressure, et cetera. So Blair, if you could walk us through sort of each of these a little bit, it would be super helpful.
Yeah, sure. So we can see there's no to little disparity, mainly little disparity with by location data for breast cancer mortality, and cardiovascular disease mortality. Also heart disease and high blood pressure mortality, colorectal cancer mortality, and injury deaths. The disparities present here, though, are really with diabetes mortality and homicides by firearm, and then a little bit of HIV prevalence, but there's definitely need for more data for that. But
and I want to highlight a little bit diabetes mortality, and it's tied to sort of our earlier slide about access to care and insurance, right? So certainly those who aren't able to see their physician, don't have coverage, have higher risk potentially of morbidity and mortality rate related to chronic conditions like diabetes, right? Hypertension is another, high blood pressure, where what you see is we don't have enough data, right? And that's sort of consistent with what we know about hypertension to be sort of the silent disease, right? Hypertension tends to be something that if you're not taking your blood pressure, you may not actually know that you have it. And so this sense that we don't have enough data is consistent with that. And then obviously our data on homicides and homicides by firearms.
So this is by location. We can move on to by race, and we see a similar pattern when we look at look at the Fs, look at the Fs, look at the Ds.
Yeah.
This has been really important data. Go ahead, Heatherlyn.
Yeah, we talk about mortality, we talk about morbidity, but I don't know that we've defined them. So EJ, what did you mean when you talked about mortality and morbidity?
Thank you for that clarification. So when we talk about morbidity, we're talking about poor outcomes that don't necessarily include death, right? So we are talking about maybe dialysis, needing dialysis as a result of untreated diabetes, amputations, unfortunately, that might be a poor outcome that is not death. Obviously, when we talk about mortality, we're talking about death, but there's so much more potential negative outcome than just death, right? Diabetes can result in blindness. Diabetes can result in poor kidney function requiring dialysis. Diabetes can result in limb amputation. So there are things that we want to consider that are beyond just mortality. And it's hard enough to get some of that data. So that's a consideration that we have to consider as well.
Yep. We have one more slide because I know our panelists are getting ready, like they want to talk about this.
Eager to talk, yeah.
I know, and I'm watching the time. So this is our last slide for health outcomes. These are years of potential lost life. And again, we're seeing a C across the board. This is defined as rate of years of potential life lost from all causes of death before age 75. And then we have one map here that looks at life expectancy. And there's so much to unpack here. I mean, there are differences in street address, that we know are significant. So this is just a taste. But again, look at the trend. Look at the trend that we're seeing here, where the darker the color, the higher the life expectancy of the population. So.
And if we had Dick on here, we would talk about all of the policy changes and implications that create a map that looks like this in the history of gentrification, et cetera.
Yeah.
So that's another discussion, but thank you so much, because I think this data really helps set the stage for a conversation about why men's health is important and the preventative screenings that are important, and we can bring Dr. Harris forward. But I want to talk a little bit with Dr. Harris about, in the context of this information we've seen, what are the things that men need to be really thinking about, or the people who are taking care of men in the community that we need to be really thinking about in terms of screening and prevention, so that we can maybe move the needle on some of these markers?
I guess there'd be a few things that I'll just kind of mention. First off, being aware of your family history is really important, especially men, as far as having preventable things that if they had kind of got that checkup or had the discussion with some of their family members, they would have kind of come in a little bit sooner. You guys have mentioned multiple times how women tend to go to the doctor more than men, but I think if men were more informed about their risks, they would be a little bit more motivated to come in. The second thing I'll say is with screenings, most of them are not a one-time thing. And so all because you go to the doctor and kind of get that catch up, it doesn't mean that you're done from that moment. It's a continuous thing to be aware of as far as returning to get those screenings again, but also understanding that as your risk factors change, those screening kind of timelines also change, and what you should be screened for also changes. So as much as we want people to kind of know what's going on with their health, we want them to also be cognizant that preparing to come to the doctor more regularly will ultimately increase the life expectancy as far as that last graph, but also improve their kind of family timeline and family lineage, because they're healthier versions of themselves, and their family is kind of aware of their own risk factors. So it all kind of plays into being aware, but also taking those steps to continuously check in on stuff and have that maintenance. We always get oil put in our cars on, at least every 3-4, well, depends on how many mileage you go. I go by mileage. Let's go over.
Depends on how much you're driving.
The point of getting that oil change is to take care of your car. That's the one thing that we do as car drivers, is get our oil change. And just like that, we need to go to the doctor regularly to make sure we're getting those screenings and checking in on things.
I want to back up a little bit. So why is this an area of particular importance for you, and sort of what are you, why is this something that's important to you as a family doc? And maybe talk a little bit about your practice and what you see in terms of men coming into your office.
Yeah, so as a family doctor, I see adults, men and women, and children, and specifically, I see a lot more women in my practice than men, and sometimes, well, I take care of them too, but what I often am thinking about is the fact that our population is 50-50. And if our male counterparts are not taking care of themselves, then that ultimately makes our community not as strong as it needs to be, and not as healthy as it needs to be. One of the things as a female doctor that I get is men kind of sometimes only wanting to see men, which everyone has their preference. Women sometimes only want to see women. Like, I definitely get that. But I want people to understand that at least seeing a doctor for your screenings is the first step. You can find what doctor you want as far as preference and personality and what time their clinic is open, whatever it may be. But screenings are all the same. Whether you're a man or a woman, like, there's differences based on sex, there's differences based on ages, which I'll go into a little bit more, but it's definitely important to at least get that base, because it's not very specific to who you see. As a primary care doctor, family doctor, I know what screenings everyone needs, and so I can do that. And if you are able to trust me and able to kind of build that relationship, then we can do kind of other things. But I really want people to kind of focus on at least getting their screenings and kind of going from there, and not always kind of being specific about who you're seeing and trying to find that preference. It might take time to find that doctor that you really, really enjoy and really, really connect with. But the screenings need to happen based on whatever timeline and frequency your risk factors speak on.
And we're going to get into that timeline and frequency. I know you have that info for us. Thank you so much. I see Dr. G with her hand up, and she's out in the community, and I want to bring her forward and let her go ahead, Dr. G.
Hi, good afternoon, everyone. One of the things that's in our community as far as men, they have a fear, not of just going to the doctor, but a fear of when they get the screen, the results. So, I had a couple of young gentlemen, they had some abnormal test labs, and they didn't want to follow up because I don't want to know. So is that kind of like oblivious? I'd rather not know. Same thing with STD testing. People like, well, if I have it, I just don't want to know. But we just have to push that narrative, break that stigma that, if you get the preventative screening and testing, then you have better outcomes. But that's one of the biggest things, is that fear of knowing. So they kind of want to be oblivious sometimes.
And
So
I
how do you
think
think?
that's super important context, right? Because it's something we can be setting the stage for in our visit, right? Setting the expectation, we're going to bring you back and we're going to discuss next steps and we're going to have a conversation. Because oftentimes, as you alluded to, it's the fear of what's going to happen if this isn't the result, but also the fear of what am I going to do? Right. And so if we're having a conversation about the fact that we will be there with them for next steps as providers, that we will make sure that we connect them with the appropriate resources, et cetera, then we can dispel some of that fear. Right.
Yes. Great. Thank you.
I just want to
Yeah,
pick.
I think that's a great point as far as the fear, and depending on what type of relationship people have with their providers, some of us are a little bit more apt to kind of explain those next steps, so that way that brings some comfort, because the unknown is a big part of health. Like, we do not know what's happening next week or next month or next year with our health. But the idea is that we're preparing as much as possible. But when it comes to screenings, and not just screenings, but other kind of health problems that you're managing, keeping the patient informed as far as what's going on now and what may happen later, and what may be the next steps as far as things to kind of come back for, are all part of that process of building that relationship and building that trust with your patients, so that way they know that you're here for them, that you're in their corner, and that they don't have to be afraid of the results, and that the next steps, you kind of be a team with it, and your doctor is going to continue to be a resource for you. But yeah, that fear definitely keeps them from walking in the door, and that's across the board for men and women, actually.
Thank you.
Dr. Harris, would you give us some context for what screenings and preventative health that is necessary per age group, right? So if we've got, young adolescents, what sort of screening should they be getting? People who are in their 30s, what sort of screening should men in that age group be getting?
Yeah, so I thought about it in like the 20s, 30s, 40s, 50s kind of grouping. A lot of these are similar. I'll say by default, kind of as you get older, it doesn't really get smaller as far as the number of screenings. And so there is a lot of overlap in that sense as far as the foundation. But for people who are in their 20s, there's not a lot of specific screenings as far as the colonoscopies, for the prostate cancer kind of screenings, but everyone should be screened for their mood as far as anxiety, depression. There's STD screenings that should be happening based on people's risk factors. And one risk factor is really just having sex without a condom or having multiple partners in general. People in their 20s and above should be screened for their substance use. So how much alcohol they're taking in, different conversations with different people. Any form of alcohol is not a good intake, but there are ranges that we like to look at as far as heavy drinking or binge drinking, tobacco smoking, marijuana use, heroin, different drugs like that are all part of the screenings that we do for people in their 20s, as well as kind of eye exams. I know that's not like regular thing as far as like your vision test, but it is recommended that at least in your 20s, people do get one eye exam, just so you know what's going on and you aren't just kind of relating to, oh, it's harder to drive at night or I can't quite see as well. We do want people to get those screenings in general, as well as just blood pressure based on your risk factors of your family, your body kind of weight, your diet. That should be something that regularly happens at the doctor, if not at least every few years in general, if you don't have that many risk factors. As far as in your 30s, it's all the same things that I just said about your 20s, as far as your eye exams, your mood, your blood pressure, your STD testing, your substance use kind of screenings. But in addition to that, we start thinking about your diabetes a lot more. And so specifically after the age of 35, and those who have extra weight or are overweight, we do recommend that people get blood sugar screenings, but that also may happen earlier, even in your 20s, if you have risk factors based on your family history, symptoms, like if you have extra kind of more like severe extra weight in general. But at least by 35, everyone should be screened for diabetes. When you're in your 40s, the list gets a little bit longer. We start talking about going to the eye doctor a little bit more frequently, as far as a couple times in your 40s. But then colonoscopies come through. In the last couple of years, a few years, the age went from 50 to 45 as far as no risk factors, just average general risk. And that should be sooner, actually, if you have a family history. If someone in your immediate family has had abnormal colonoscopies, depending on what they found, you should get your screening 10 years before that abnormal colonoscopy age for your family member. But at base, everyone should start doing their colon cancer screenings at the age of 45. And I do want to say that looks different for different people. As long as you have a normal risk, it could be a colonoscopy. They also have stool tests or poop tests that you can do that they can send to your home and they can send out. The colonoscopy gets you the biggest range as far as normal, and you get 10 years. And the stool test can get you a few year gap if you do that. So that is something that has become a little bit more popular in general. And then in your 40s, people also start looking at your prostate health for prostate cancer. Especially you have risk factors in our African-American and Hispanic communities at base. Just being African-American or Hispanic is a risk factor. And so people in their 40s with those races tend to get screenings a little bit earlier. I know I personally do it in their 40s just because I have a lot more African-American population, but the true one is more in your 50s. And then depending on what's risk factors you start having in your 40s, we also start doing cholesterol screening, just cardiovascular screenings in general, as well as keeping that substance use, the STD testing, the blood pressure test, all those kind of stay true. Now, when you start getting to your 50s, the colonoscopy is definitely something that is recommended, even though the 45 is the new age, 50 is what people always think of. So if that's what you remember, we at least want to do it in the 50s. We also start doing lung cancer screenings based on your smoking history in your 50s and kind of keep the prostate cancer screening at base, whether you have risk factors or not. They start in your 50s too. But the blood pressure check, the blood sugar check, the STD testing, like I keep saying that, like STD testing is not just for your 20s and your 30s. Like you can be asymptomatic and you're also still sexually active in your 50s. So all these things still run true. And then the substance use, as far as alcohol, tobacco use, marijuana use, other drug use, those are all kind of consistent screenings that we continue to do. In your 60s, everything kind of continues as far as the same things that are in your 50s, but what we start getting more frequently is the eye exams start happening more frequently because glaucoma, as far as increased eye pressure, is a little bit more prevalent when you're older, as well as kind of other eye problems. Just because you wear glasses, like that's one eye problem, but the eye is its own organ. And so there's a lot of other problems that can happen that you can't see just on the outside. That's why people get their eyes dilated. That's why people get eye exams where they're looking more closely and they can see your nerve health, your blood vessel health. So you start getting your 60s, you should be getting yearly eye exams, whether you wear glasses or not, but also because you might have medical problems that could be impacting your eye health, like diabetes, thyroid disease, blood pressure disease, all those things impact your eye health. But for your 60s, this is kind of the last age group, but the lung exam for lung cancer still stands true. Prostate cancer screening still stands true. Now, I didn't say this before, but prostate cancer screenings, it can be a blood test. And so it's not the rectal exam that historically is present. I prefer as a primary care doctor to do blood tests, and it has shown to be very effective to tell us about your prostate health and what's kind of going on. I will mention that if you're having abnormal kind of prostate labs, that doesn't mean that you have prostate cancer. There's just next steps that we should do, but there also is an ongoing enlargement of the prostate that normally happens for men as they get older. And that's something that we kind of watch for too, because you can have urinary symptoms related to that. But all these things, I know the list kind of got longer as we kind of aged the group, but there are screenings that exist. We talk a lot about mammograms. We talk a lot about pap smears for women, but men have their own prostate cancer is their kind of solo screening that's specific to men. But all these things that I said about men kind of go also with women outside of the prostate part. But men need screenings too. There's been a lot of studies about the importance of these screenings, how preventative they are, and how amazing the impact is once people do get regular screenings and take care of themselves. And all because you're getting screening doesn't mean there aren't any other chronic medical problems that people should be addressing. So There is a long list, and this is what you're having a good relationship with your doctor. Why it's important, because we know these things like the back of our hand, and we really want to help you prevent things so we don't have to watch complications happen or watch kind of quality of life go down. We really want people to be the healthiest versions of themselves.
I appreciated the concept, the statement that the list got longer as you got older, because my list as I go to the doctor gets longer every time I get older too. So the screenings are longer and the problems are longer, and we should just extend our doctor's visits as people get older, because that just feels so true. Super thank you for all of your expertise and talking to us about screening. I've asked Dr. Shan and Jamika Thomas from Genesee Health Plan to pipe in, because one of the things we talked about earlier was this idea that there are barriers to getting the screenings that Dr. Harris talked about. And Jamika, I wondered if you'd give us a little bit of context for where Genesee Health Plan is thinking about how we can help people get rid of those barriers or resources for people to get access to insurance and get access to care.
Absolutely. It has been the mission and vision of Genesee Health Plan to help folks get connected to healthcare coverage. As we all know, healthcare screens and education and preventative care, we need healthcare coverage. So what the county health plan does is we like to say, get it, keep it, know it, and use it. And we're talking about healthcare insurance. And a lot of folks don't even understand the language of healthcare insurance. So that's where the Genesee Health Plan comes into play, is we try to help folks to understand their healthcare coverage, how to use their healthcare coverage, and how to keep it. As we all know, we've been in a public health emergency, which has now come to an end. And so with the state of Michigan, we're in an unwinding phase, or what they would call a redetermination. Folks are starting to have to go through the process of redetermining their eligibility for state coverage for Medicaid. And the health plan is here to help in those efforts to help folks understand their coverage, to reapply for coverage, whether it's Medicaid, whether it's Medicare. We have MAP counselors here at the county health plan to help with that, whether they need to shop for insurance through the marketplace, or even if they are eligible for Genesee Health Plan, which is funded and supported by the residents of Genesee County and millage dollars. So I like what Dr. Harris was saying. In the health plan's goal is to help folks establish a trusted relationship with their primary care doctors, so that they can have someone who's aware of their medical history and help them to manage their conditions and just not receive that episodic care. Just when there's an emergency, they go to the emergency or urgent cares, but they have someone to help them manage their high blood pressure, diabetes, cholesterol, mental health, and those sorts of things. So the county health plan has been just about that, using your insurance for primary care services and establishing a medical home. And that's been our mission here. And we've tried to reach every inch of Genesee County, all populations of folks, even those individuals who are returning citizens, those whose primary language is not English. We've tried to cover all the bases here at the county health plan to help support those in understanding healthcare insurance and benefits.
Thank you so much. This is such important information that people need to be aware of. And if you could put your contact information or how people should engage with the Genesee Health Plan if they need resources in the chat, it would be so perfect for our listeners and our followers. Dr. Shan, one of the first things that Dr. Harris mentioned when she was talking about screening is that everyone needs to be screened for mood, and we need to be really thoughtful about that. And even Jamika was talking about the importance of mental health in this conversation about preventative health. And I wondered if you'd give a little bit of context to the work that you've done in this space and why it's so important to think about mental health as we talk about men's health.
Mental health is really big when it comes to men. A great large of my caseload has been men, even to hear Dr. Harris speak about genetics, because genetic is big. You know, like 30% of a man's overall health is determined by his genetic, but 70% is controlled by his lifestyle. So it's about what he's putting inside his body, and it has a lot to do with how he controls his mind. So if he's not eating right, he's not going to be acting right or responding right when it comes to certain things. Even hearing Dr. Harris saying there's a lot of things that go into like the screenings, knowing how long he's sleeping at night, because a lot of men are not sleeping. They carry a large of the bulk of the family to keep things moving productively, and that affects their mental health. They're sleeping like less than 5 hours. A lot of them don't sleep at all. And so they're not taking care of themselves on that. Their mind are not resting. That means your organs are starving. They're not eating properly. But then also just a lot of people are not physically active. That if you walk at least 50 steps a day, it reduces your chances of a heart attack by 25%. And a lot of people not moving. They claim they don't have time to move, but yet they sit and watch Netflix majority of the day. So you have time to move. I definitely major salute to Dr. Harris. We're trying to push our men to get out there, and there is a fear of, I'm like, have you ever got your prostate? I'm not gonna bend over and let nobody do nothing to mine. And I'm like, no. If you're trying to be here for longevity and you're trying to be here for your kids, that's one of those requirements. And so how do we break that barrier of making the conversations with them that it's okay? And it goes back to what Dr. Harris said, the trust. They don't trust people. And we're in a community right now where trust has been really broken in every area, from General Motors leaving to we had the water crisis, and boom, here come COVID. So it's been a lot of post-traumatic stress going on within the city of Flint. But we go back to the men who have this bulk of their families on their backs. And these are men that's known now to suffer in silence, because it's not okay for a man to complain, because this is his job. And so at first we had it where we were within a world where women were committing suicide, and now we're in a world where men are doing it. 76% of the men are doing it versus 26% of the men. But out of those men that's actually doing it, like I think the stat was 3.3 of them, suicide death is for every one female that commits it. So men are doing it quicker than women are. The weight of the world is on their shoulders. So I educate them on how do you eat when you're depressed? How do you eat when you're going through anxiety? Because there's certain foods that you can put inside your body that would trigger these things. So I go back to speaking about that Mediterranean diet, getting those dark leafy foods inside your diet, eating a lot of nuts, eating a lot of berries, going on those walks and getting your mind together and just breathing. But having someone like Dr. Harris, that when you go to the doctor, you can talk to your doctor. And she can make those connections for you and say, hey, I got this really good therapist that you can talk to. It's okay to have a therapist. It's okay. No one has to know, but they kind of help you navigate through this thing called life, because we never got a book with this thing. We're just kind of thrown into it called life. We're kind of thrown into parenthood, no book. And so your doctor usually is the person that you vent to, or your barber, or the person that does your hair, and you vent in those zones. But find somebody that you can talk to kind of help navigate yourself, because those small things can help you, just having that conversation, but also changing the way of you eating. Healthy eating will help prevent prostate cancer, especially when they catch it very early. You're going to probably go through the screening. They're going to say, hey, they're going to give you the number where you're at. You may go through a little chemotherapy, but guess what? You got to eat right with it as well. That has a lot to do with it. But a lot of people, when they're going through cancer, they stress. And so we have to be able to communicate with them and saying, hey, you need to find an outlet with someone so we don't push this tumor to grow fast because you're stressing. So food has a lot to do with it as well. And so that's what I talk about within the community, how, it's okay for you to find that outlet and find that doctor that you trust.
I love this. I feel like I want to start the webinars with, we're gathered here to talk about that thing called life. Like, I feel like that should be the context for all of our webinars from now on. You can feel free to come on anytime. I heard a couple really key points there. I heard find a provider, someone who you trust to help you think about your preventative health. Be thoughtful about what you're putting in your body in terms of nutrition, get those lean green vegetables in. It's okay to talk to a therapist. What I appreciated that you said is no one has to know, right? Even during COVID, when we were talking about vaccines, you know, there was this, oh, my family's going to feel some sort of way, or someone's going to know I have a therapist. Your relationship with your provider, whoever you see is your relationship. They cannot tell anyone. You don't have to tell anyone. You should do what's best for you. And I think I really appreciated that point. You had one more thing that you said that I thought was so important. An outlet. Find an outlet, whether that's taking a walk to get your mind cleared, whether that's a run, whatever you do, have an outlet. I would love to bring you back to talk about more of those in detail. And so thank you so much for your expertise today, Dr. Shan. I really appreciate it. Thank you, Jamika, for coming here to talk about the resources that Genesee Health Plan has. Thank you, Dr. Harris, for talking about the screenings. This is a short introduction to men's preventative health and the things that we need to focus on. In coming weeks, we're going to be unpacking some of these singular issues that we talked about. So thanks to Dr. Harris for getting us into the idea of what we need in terms of, you know, preventative screenings, but we're going to get to talk about what does colorectal screening look like and what are the different types? You alluded to some of those, and what is the risk in certain populations. Any last thoughts from you, Dr. Harris or Dr. G?
Can we debunk the myth? A lot of people, when they come to the physician, like you said, the list gets longer. So they say, well, just like a car. Every time I take my car to the mechanic, I go in for an oil change, and now I got to have the transmission. So can we explain why is that? It's because if you don't keep up, like I said, the proper screening, that sometimes those things are uncovered when you're there. But sometimes they just want my money. They just want to run all these different tests. But can you kind of cover over that again? Like, why is it like when they come in?
Absolutely. So we will absolutely bring that back up. I don't know if Dr. Harris has any like a 1 minute summary of why we need to keep the oil changed on our car, our proverbial human car.
When we get the oil change, but like when you go get the oil change and then they find out, hey, your filter's dirty. So they think that, I've gone, well, every time I go, I just need an oil change. You need your tires rotated, they're bald. So just how that screening is able to uncover all those different things, and not that it's just on purpose that people are running an unnecessary tests.
Exactly. I mean, I bring people in every single time because I always give everybody an opportunity to give me what their dream car would be. And someone will usually say Maserati. I said, so you really telling me that you would drive your Maserati to a gas station and put unleaded fuel in it and knowing it needs premium? Look at your body as a Maserati, that you're going to keep nothing but premium things in there. That means you're going to put good things inside your car. You're going to clean your car all the time. That means that's your body. You're going to keep it clean. And so people kind of identify with that. Knowing that they got this luxury vehicle that they're walking around with, and they got to keep this luxury vehicle together for longevity, that they don't want to have those small little glitches along the way. They want to keep all this good stuff inside this luxury car, which is your body. And then you have people you need to be here for. So you're going to ruin this body, and there's other people depending on you. So you got to take care of your body, because usually it's going to be the first to go and then your mind is right behind it. So definitely everybody is riding around in their own Maserati. I tell them with their bodies and the things that they put in it, it got to be the good things and not the bad things.
Thank you so much.
I'll add to that as far as why the list kind of continues to get longer. At base, you're using your body more. So as things get older, the wear and tear starts to add up, and you're not, a 3-4-year-old who just came into the world and like everything's fresh. Like you've been using this body a lot, and over time, like Dr. Jackson was saying, like you're not putting the right stuff in your body, and so it's using that information, those substances and stuff to turn over and try and fuel your body. But if it's not the right fuel, it's not going to be the best. If you're not moving as well as you should be, your bones and muscles and joints and things are not going to be the healthiest. But also, as you get older, your cells and things turn over, and so as things are aging, just in the micro point of your body, as you keep turning things over, there starts to be more and more errors. There starts to be more and more mistakes with how your body is growing and moving. And those errors and those mistakes are what causes cancer, what causes different diseases, what causes changes in kind of how your body is breaking down stuff. So it's not the same body as it was 20 years ago, because all these different errors and changes are starting to happen in your DNA. And that's what makes you a little bit more prone to diseases. And so the reasons we have screenings at a certain age is because all this research, all this evidence has come along to say, yeah, people have gotten this disease at 50, but if we start the screening at 30, then we can prevent that problem from coming. And so that's what all this evidence-based medicine has come out to, as far as why at certain points we get screenings and why we, have different frequencies of those screenings. So that way we can prevent that long-term problem. It's all kind of information and us becoming more knowledgeable as far as modern medicine to be able to keep our bodies as healthy as possible. But age is going to happen. There's no way to kind of prevent that. And so we need to take care of ourselves by doing these screenings overall.
Thank you.
Thank
That's
you
a great
so
answer.
much, Dr. Harris.
Yeah.
All right. We will be following up with more men's health topics. And thank you so much to all of our amazing experts for talking to us a little bit about this. I want to end by highlighting some of the amazing work that some of our students have been doing. And we'll start with Kenyatta Dotson, who works with PPHI and the Flint Registry, and is going to highlight the work that some of our students have done. And I know, I apologize, I didn't save you enough time, but we'll bring your students back to talk a little bit more in depth about their work. But if you could just give a little summary of some of the work that you've been doing in service of the Flint community.
Hi, the students are actually on the line, so they're going to do a quick overview of what they've been doing over their time. So they are awesome and phenomenal. We have MiCHWA and Alyssa, who's representing the entire group. So I'll turn it right over to them. We thank you for this opportunity. Today is their last day, so they have a lot going on today, but they also took time out to be with us on this awesome webinar. So I'll turn it over to MiCHWA and Alyssa.
Thank you both.
Thank you so much, Dr.
MiCHWA, I think
I'll go ahead and
Oh,
start.
okay, go ahead. You're on mute.
So this summer, oh, can you hear me?
I'm not sure who's speaking, but you're broken up a little bit.
Oh, shoot. I'm sorry. I'm at the church right now. Julie, how about you go ahead?
Yeah,
Okay.
sure. And I can talk about your event a little bit too, Alyssa. But so one thing that I've been working on as we're talking about mental health so much is a mental health summit. And that was last week. And I had panelists from the outreach and communications team work together to put together a summit. And we had panelists who were working in the mental health landscape across Flint and Genesee County come and share resources, share their expertise, share what the landscape is looking like in Flint. And I just thought that was really important because, as you guys mentioned, it's hard to understand the resources. It's hard to understand what your insurance covers, what it doesn't cover, what one type of resource means versus another. So I thought that would be a great resource. So I was really glad to get to work on that because it's something that I am very passionate about. And then Alyssa and her team right now are creating this event called Healthy Eats and Happy Feats, where they are going to have a food demonstration, a dance class, all sorts of family-friendly events at Asbury Church to encourage healthy eating, to encourage movement, and just overall taking care of your body. Like, as I say, it takes a village, and it takes a village to keep people healthy and to keep kids healthy. So that is what they're doing today from 2 to 6 p.m. at Asbury Church. We are very excited for that event, and it's going to be great. And I don't know if Ruby's here and wants to talk about her event. Kenyatta, is she here, or should I just mention?
Yeah, if you can mention it, I don't think she was able to join us.
Okay, so Ruby and Kenyatta and Kwan all worked on this amazing event called the Intergenerational Summit, and that aimed to bridge the gaps between the older generation, the younger generation, and it was a great conversation. I know that I shed a tear, and I'm sure many other people did too, between, what people can learn from each other, what they understand about each other, what they don't understand, and it was just a great connection to make. So yeah, that is what we as the interns have been working on, a couple of the events, and we've just had a blast here for the duration of our internship. And I know that I'm very sad to leave, and I'm sure the rest of them are too. So yeah, thank you guys for listening.
Yes, no, thank you for sharing the work that you've been doing that's really consistent with sort of the needs that we have in the community, right? So I love hearing about the mental health summit. I love that as students, you're coming to do work that is in service of the needs of the Flint community. And I didn't know if Alyssa wanted to give one last shout out. It looks like she is okay now. So
Yeah, can you guys hear me?
we can.
Oh, perfect. Okay. Yeah, thank you, Joey, so much for advertising our event and summarizing a fantastic event. It is from 2 to 6 once again at Ashbury Church. If you guys can come on by, we'd really appreciate it. But just want to also highlight that like community feedback is so important for creating events like this. Knowing what we're doing in the community is necessary and needed. At our event, we're going to have a feedback form for people to fill out, but just continue to involve the community and see what's working, what's not working, because if we're doing an event, it is for the community. It's for nothing else but that.
Thank you both for the work that you've done. Thank you, Kenyatta, for supporting these wonderful interns and the work that they've done and all of your work with PPHI and the Flint Registry. Thank you all for this wonderful discussion around men's health. Please join us next week. And these are the CUs for community health workers. We're looking forward to seeing you next week. Thank you so much for your time and attention.